Oral tongue. Oral tongue constitutes the anterior two-thirds of the tongue and is made up of a vast array of muscle fibers allowing the tongue to move in almost any direction. The function of tongue is crucial for speech, swallowing, mastication, oral competence, taste, dental hygiene. Cancer of the tongue do not need to be very large to cause a drastic effect in any of this function, and with essentially no barrier to spread, tongue cancers can spread easily. The circumferent papilla locate the division between the oral tongue and the base of tongue. Anti-arterial supply is via the lingual arteries coming from the external carotid. The sensory pathway is by way of the lingual nerve to the Gazerian ganglion. Taste fibers travel through the chorda tympani via similar route. Arterial supply is via lingular arteries, sensory pathway is via lingular nerve to the Gazerian ganglion, and taste fibers via chorda tympani nerve via similar route. 95% of the cancers in the tongue will be squamous cell carcinoma. Coexisting leukoplakia is common. Varicose carcinoma and minor salivary gland tumors are common. Glandular cell myoblastoma is benign tumor of uncertain origin that occurs on the dorsum of the tongue and may be confused histologically with carcinoma. Pattern of spread primary. Most oral cancers begin in the lateral or ventral surface of the tongue, and advanced lesions invade floor of mouth, the root of the tongue, producing ulceration, fixation, and posterior third tongue lesions grow into the anterior toxicopillar base of the tongue. Perineural invasion, vascular space invasion, they are not uncommon, while lingular neurovascular bundle. Lymphatics, the first echelon nodes are the level 1B and 2 nodes, followed by level 1A and 3. Rouviers describe lymphatic trunk that bypass the level 1 and 2 and terminate in level 3. And Byers et al. Evaluated nodal spread patterns 277 patients surgically at MD Anderson and observed skip metastasis to level 3 or 4 nodes without involvement of the level 1 and 2 is seen in 16% of the patients. So of patients with oral tongue cancers, 35% have a clinically positive nodes at diagnosis. 35% have a positive node at the time of diagnosis and 5% are bilateral. So incidence of occult disease is approximately 30% and the incidence of positive node increases with the T stage. N1 or N2 ipsilateral nodes have a significant risk of developing node metastasis on the contralateral side. Mild irritation of the nerve is the most frequent early complaint and also develops, that is pain worsens and is referred to the external auditory canal. Extensive infiltration of the muscle of the tongue affects the speech and deglutition, and the extent of the disease is determined by visual examination and palpation. The tongue protrudes incompletely and towards the side of the lesion as fixation develops, and posterior oral tongue lesions can grow behind the mylohyoid and present as a mass in the neck at the angle of the mandible, and invasion of the hypoglossal nerve is rare. Treatment mass selection of treatment modality like both surgery and RT results in a cure rates that are similar for less advanced stages of the disease, and combined modality treatment is required for more advanced tumors. As with floor of mouth cancers, the advantage of surgery include less morbidity, and with modern reconstructive technique, functional and quality of life outcomes they are excellent. For resected tongue cancers, RT can produce worse functional outcomes with high risk of trismus and chronic neuropathic pain, dental damage, soft tissue necrosis, and osteoradionecrosis. Excision biopsy. An excision biopsy of a small lesion may show inadequate or equivocal margins, and interstitial implant or re-excision will produce high rate of local control. Early T1, T2 lesions, partial glossectomy with primary closure or skin graft may be done transorally and is usually preferred therapy. And once the defect is greater than the 1/3 of the tongue, free tissue transfer reconstruction provide long-term functional outcome. For moderately advanced lesion like T2, T3, the preferred treatment for majority of the lesions is glossectomy, neck dissection, tongue reconstruction, post-operative RT or chemoradiotherapy based treatment. For advanced T4 lesions, aggressive treatment. Many patients can be cured with excellent functional outcomes and reasonable quality of life. Surgical treatment for early lesion T1, T2, partial glossectomy and primary closure can often be performed, and deeper lesions may require a more extensive resection and the necessity of reflap. Moderately advanced T2, T3 lesion, partial glossectomy with primary closure, skin graft, flap reconstruction is performed, and frozen section control is essential. Positive margins are indication for excision of this additional tissue. For advanced T4 lesion, near total or total glossectomy, sometimes laryngectomy performed on ongoing or functional reasons. Approximately 50% of the patient will achieve usable swallowing and speech function, and the appropriate patient selection is of utmost importance. Irradiation technique, ability of the control primary lesion is enhanced by giving all part of the treatment an interstitial artery or intraoral cone. Superficial T1 lesion may be treated with iridium 192 brachytherapy along with the plastic tube technique. Large lesions have an increased risk of subclinical neck disease, may be treated with external beam RT and brachytherapy boost, or with brachytherapy combined with an END, external neck dissection, elective neck dissection. And the time factor is critical for oral tongue. External beam RT part of the treatment is shortened 30 gray in 10 daily fraction or 38 gray 1.6 gray twice daily fraction in order to increase the proportion of RT given by either interstitial or intraoral cone therapy. Interstitial therapy is given after external beam RT. The intraoral cone therapy should be done prior to external beam RT, and ENI is indicated nearly for all lesions. Combined treatment policies, post-operative RT chemotherapy administered to primary site neck for indication of previously outlined IMRT may be useful to reduce dose to one or both parotids. For recurrence, local recurrence after RT or surgery heralded by ulceration, pain, increased induration, recurrences have a slight elevated or rolled borders, and whereas necrosis do not. Recurrence, they have elevated or rolled borders, and necrosis do not, and the biopsy should be done as soon as ulceration appears if it is within original tumor site, and ulcers that appear on the adjacent tumor tissue are likely due to RT and not cancer, and however some recurrences occur deep within the soft tissue and are difficult to diagnose without extensive deep biopsies, and RT failure is managed by surgery. Surgical failure occasionally salvaged by re-excision post-operative RT. Recurrence in the soft tissue of the neck is rarely eradicated by any procedure, and nodes appearing in a previously untreated managed by neck dissection and post-operative RT chemoradiotherapy. Results of treatment, local control rate is 1 in some 170 patient by RT alone versus surgery alone, or with RT between 1964 to 1990 in the Florida. For T1 it is 79% versus 76%, so surgery versus RT. For T2 it is 72 and 76%, T3 it is 45 82%, and T4 0 versus 67%. The difference in 5-year survival rate between the two treatments not statistically significant. The results of brachytherapy alone or combined external beam RT for 448 patients at the Central Alexis Weldon reported revealed following 5-year local control and survival rate. For T1 it is 93 versus 69, T2 65 41, T3 49 25 respectively. A shorter time interval between the brachy and external beam RT associated with the significant improved local control and survival for those who received both modalities. Complications, surgical complications like infection, poor wound healing, scar, or cutaneous fistula, flap, partial, full necrosis, dysphonia, dysphagia, most common complication after surgery. Unplanned damage to the lingual nerve, hypoglossal nerve is rare, and nerve resection may be necessary for cancer resection, and incidence of complication increases after surgical salvage attempts after RT failure as well as RT plus chemoradiotherapy in general. Radiation therapy, a minor soft tissue necrosis, is fairly common and is treated with broad spectrum antibiotic, local aesthetics, viscous lidocaine, analgesics, and pentoxifylline is 400 mg thrice daily is often beneficial. Hyperbaric oxygen treatment may be tried in difficult cases, and if the necrosis is persistent, the pain is uncontrollable, it may be resected. Edentulous person less likely to develop bone complications compared to patients who are dentulous. And the most frequent problem involving the mandible is bone exposure. If the patient is dentulous, they should be discontinued. They should be discontinued or altered to relieve the pressure over the exposed bone. If sharp bony edges appear, they are filed, and the bone edge is lowered to speed healing, and healing may require months to even years. Osteoradionecrosis developed hyperbaric oxygen has been used in some cases, and Pentaclo protocol utilizes a cocktail antibiotic of antifungal, oral rinse, steroid, vitamin E, pentoxifylline, and bisphosphonates to promote healing. And the protocol takes months to improve vascularity of the necrosis area, but may lead to complete healing or may be used peri-operatively to improve surgical outcome. And the average time to healing is 9 months. If conservative measures are unsuccessful, segmental mandibulectomy, osteomyocutaneous flap reconstruct is performed, and in severe complication, 9 out of 105 patients treated with RT at University of Florida, Pernot and colleague observed following soft tissue bone complications in a series of 448 patients, grade 1 19%, grade 2 6%, and grade 3 3%. Thank you.